Good afternoon. I'm Jamie, and I'm here with Doctors David Steckel and Dr. Setu Patolia. They are both SLU Care pulmonology disease specialists. Dr. Steckel and Patolia are board certified in internal medicine, pulmonary disease, and critical care medicine. Today, we're going to be discussing the newest treatment option for adult patients with severe asthma. We'll take your questions live today during the presentation, or you can ask your question in the comments area of this post. So thank you for joining. We're going to start with Dr. Patolia. What is your primary goal in treating your asthma patients?
Well, asthma I consider as a chronic and progressive disease. Chronic in the sense that it has ups and downs, and over the time the disease progresses, and sometimes the disease becomes irreversible. So my primary goal in the management of asthma is to A, prevent ups and downs, that's what we call as exacerbation, and B, to prevent the progression of the disease where the patient becomes totally bedbound. Inherent in these goals are preventing the exacerbation, preventing the emergency room visits, preventing the visits to the doctors or using the steroid. Also, preventing the use of rescue inhaler every day. Ultimate goal is patients should be able to do whatever they want to do. They should be able to enjoy their life to the fullest extent. There should be no limitation to their physical activity. And they should not be afraid to do anything because that they are afraid that asthma will exacerbate. So that's my primary goal of treating the asthma.
Thank you. Dr. Steckel, what are some of the challenges and frustrations that you've had with asthma treatments over the course of treating patients over your career?
Yeah, I think one of the biggest frustrations for both me and for the patients is the need for, it's a chronic disease and the patients need chronic therapy. So they've got to make sure they're taking their inhalers appropriately, and they need to take them usually somewhere between once and up to maybe 4 times a day, depending on what they're using. So there's this chronic need for chronic treatment, which can be, difficult to do. And patients, they'll forget doses, and then their asthma won't be controlled as it should. Also, they need to avoid things that trigger their asthma. Well, that can be very difficult. At this time of year, being outside, if you're allergic to trees, you want to try to avoid being outside exposed to all these tree allergens. But how do you do that? You can't just confine yourself all spring long. So trying to avoid triggers is also very difficult for these patients. And then there are those patients, and I think these are the patients that we're going to be speaking about, who have very severe asthma, and despite the very best treatment that we can give them, their asthma still isn't controlled. That's very frustrating. And then finally, some of these treatments are also very expensive for the patients, and that becomes a problem also.
Great, thank you. Dr. Patolia, what are some of the biggest frustrations that you've seen with severe asthma patients?
As Dr. Steckel mentioned, this is a chronic progressive disease. It's difficult to avoid all the triggers, and sometimes we don't know the triggers. So let's say a patient comes with asthma and we did allergy testing and there is nothing. Patient is on a maximal therapy. Now, what to tell the patient? If patient has some trigger, we can always tell them to avoid the trigger if possible, like dog or cats, not the season. But if there is no triggers, then it becomes difficult for us to tell the patient, this is what you should do to avoid your asthma exacerbation. What in turn this lead to is, as the disease progresses, the disease starts to become irreversible. And at that point in time, none of the therapy available currently works. So it's frustrating to see the patient to go through that extent, become short of breath, and now confined to their rooms or their house for the rest of their life. Patient comes and tells me that, oh, I'm not able to walk even to my restroom. And that's very frustrating.
Dr. Steckel, how do you evaluate new therapies for your patients who may not have any other options?
Right. Well, first of all, we look and see what options are available. And if we're talking about patients that we're typically seeing, patients with severe asthma, we'll look and we'll see what kind of asthma do they have. There's different, the term we use is phenotypes. There's different phenotypes of asthma. A patient may have a phenotype where they have very high IgE. IgE is an immunoglobulin, something that your immune system makes that's in the blood. And certain patients with asthma have very high IgE levels. Those patients may be candidates for one of the new injectable medications. There are patients with asthma that have very high eosinophils. It's a type of blood cell that we find elevated in some patients with asthma. And those patients, there's also a number of different injectable medications that they may be candidates for. There are also a number of patients that don't fit into either of those types, and so then we have to look at other options, one of which would be bronchial thermoplasty, and they may be candidates for those. So we look at what's available for these patients. We also look what they've already tried in the past. And then after we choose what are the possible options, we look at the data and we say, how robust is the scientific data that suggests that treatment A would be beneficial? And we look at the risks from the studies that have been done. What are the risks of this treatment? Mm-hmm. And we try to balance that for each individual patient and decide, would this be a treatment that is beneficial and should be offered to the patient?
Dr. Patolia, what kind of patient is a good candidate for bronchial thermoplasty?
Well, bronchial thermoplasty was studied for the patient who have severe persistent asthma. That means they have tried the maximal dose of inhaled steroid along with some other medication like long-acting beta agonist or some oral therapy. Despite this maximal therapy, they are uncontrolled. That is decided by how frequently they exacerbate, how frequently they go to the emergency room or use their rescue inhaler. So first, patient has to be uncontrolled asthma despite maximal therapy. Second, patients, we look at the patient's number of exacerbation. It has to be less than 3 exacerbations per year. Any patient who has severe life-threatening asthma in the past is not a candidate because there is some side effect of the treatment, and we do not want to offer the patient to compromise their life or their quality of life. Patient who has emergency room more than 3 times a year are not a candidate for asthma bronchial thermoplasty therapy. So these are the things we look. We also want to make sure that they're not smoker, and if they're smoker, they'll quit for at least 1 year before we offer the treatment.
Mm-hmm. Now, we have some animation today from Boston Scientific about the procedures. So, Dr. Steckel, can you walk us through this animation as we see it?
Okay, so it's bronchial thermoplasty is a bronchoscopic procedure. We use a bronchoscope. The bronchoscope goes down through the lungs into these little airways we call bronchioles. And you can see this bronchiole here is spasming like you would expect in a patient that has asthma. This long, thin bronchoscope, we feed down into the airways. And we're able to guide this visually. So here we got the bronchoscope going down the trachea. We're taking a right turn and going to the right lung. And we're going down into one of the smaller airways. Then, once we get down to one of the smaller airways, we take the bronchial thermoplasty catheter, we extend it from the tip of the bronchoscope, and it has a little electrode array that comes out and makes contact with the walls of the airway. We then activate a switch that causes electrical current to generate heat along the airway wall via this electrode array, and it heats up the airway wall and thereby reduces the bulk of the smooth muscle in the airways. And what we'll do is we'll apply this in several locations, each time moving back a little bit with the catheter, and then move to another location in the lung to perform this procedure. And by doing that, we have the whole we treat a substantial portion of the lung and reduce the smooth muscle in those areas of the lung.
That's really great, thank you. Do patients, Dr. Patolia, do patients typically underestimate how asthma impacts their quality of life?
Yes, many times I have seen the patient underestimate their quality of life, and that is because of their asthma. So I have seen patient who comes in the clinic, and when I ask them how is your asthma, just as a blind question, they will say it's controlled. But on further questioning, if I ask how far can you walk, how frequently you are rescue inhaler, what are you doing with the change of season if that's the trigger. And when you ask those questions, you can find out that they're confined to their house during the spring season. They don't want to go outside. They use rescue inhaler 2 times a day, 3 times a day, and that's not a controlled asthma. Also, sometimes when asthma is exacerbating, it's getting worse over time. Let's say in matter of couple of days, there are indications to the patient that the asthma is getting worse. They were using albuterol once or twice a week. Now they're using 3-4 times a day, and they wait till they come and see me. And sometimes they end up in the hospital because they fail to recognize the sign of asthma getting worse. There's something you can do in between to just prevent their exacerbation from getting worse and then improve their quality of life for that period of time. So yes, many times they underestimate. Education is the key to improve their quality of life, to explain them this is what we are looking for, this is what you should be talking about, and this is the time when you should call me rather than waiting till you go to the hospital.
Thank you. Dr. Steckel, what are some of the benefits of bronchial thermoplasty?
That's a good question, Jamie. The benefits, first of all, in the studies that have been done, they found that patients who have undergone the procedure have a decrease in the number of emergency department visits. They have a decrease in the number of exacerbations. They have an improvement in their quality of life. And the amount of corticosteroids that they have used in some studies has also been reduced. So substantial benefits that really speak to an improvement in the patient's quality of life. Thank
you. Dr. Patolia, can you talk to us about how safe the bronchial thermoplasty procedure is?
Okay. Bronchial thermoplasty is a relatively safe procedure. It has their inherent risk. So first of all, the way we do bronchial thermoplasty is we choose the right patient at the right time. We want to make sure the patient qualifies the criteria which I discussed before, has right amount of spirometry, the lung function, are not in mild asthma or very, very severe life-threatening asthma. We want to choose in between patient which is right for bronchial thermoplasty. We also want to choose the right time. They should not be exacerbating while we are doing the procedure. So we also do a breathing test before each procedure and make sure their lung function is within certain range of parameter. We start prednisone treatment before doing the bronchial thermoplasty for a short period of time to make sure that they don't get exacerbation post-procedure. And this procedure is done over 3 different sessions over a span of a couple of months. The risk of the procedure itself is, in the studies, they found that 8 out of 100 patients who went for the procedure had some exacerbation which required probably short duration of the hospitalization during the study period. This is a small risk we take because the study showed that over 5 years, 78% of ER visits were avoided. So 8% risk versus 78% of ER visit avoiding is the benefit versus the risk ratio you're looking at. So yes, there is small risk, but choosing right patient at the right time with appropriate pre-treatment and post-treatment management, you can avoid possible complications many of the times.
Yeah, and Jamie, I think that's a very important point with respect to the duration of the effect, as opposed to the chronic use of different medications, which I mentioned earlier, can be very difficult for the patients. This is unique in the sense that it is in a sense, a one-time treatment. There are 3 actual bronchoscopic procedures, but a one-time treatment that has a durable effect, at least out to 5 or more years. That's unique amongst asthma treatments.
Now, we do have a question that's come in. It came in from Bill. I'm sorry, I'm going to have to scroll up here if I can. And if I remember correctly, it said, do thunderstorms or bad weather affect your asthma?
It depends on what you're allergic to. Some patients have a relationship with the humidity. And I have seen the patient asking me specifically with the humidity, their asthma control gets worse. So yes, it's possible with the humid environment, your asthma control may get worse. It's different for different patients, and that's why we call asthma as an episodic disease. As long as you have a trigger, you get episode. Once the trigger is done, you don't have any exacerbation.
Interestingly, many patients too, after it rains, because you wash a lot of the pollens out of the air, et cetera, a lot of patients may actually breathe easier after a thunderstorm. So.
We do have another question from Jeffrey. Can my kids undergo this procedure?
Well, that will be a hard question to answer. Most of the time, the studies are done on 18 years and older. So there is no pediatric literature, as far as I understand, where the bronchial thermoplasty was studied. So I would not recommend, or I would ask them to talk to a pediatrician to see if it is safe. Mostly these are all done under adult populations.
And then we have another question from Doris. She says, my asthma is defined, mild, persistent, uncomplicated. Even had heart test and can still not find why it's hard to breathe. What kind of advice can you give her?
Well, I think she needs to speak with her physicians and bring it to their attention that she's still having difficulty breathing. When patients are referred to us for consideration for bronchial thermoplasty, a good proportion of those patients, after we go through all our testing and analysis, we find that they don't have asthma, they have something else, or maybe they have asthma, but what really is causing a lot of the symptoms is some other diagnosis. So, it's possible that she has mild persistent asthma, but there is, she may have one of a huge laundry list of things that may be causing shortness of breath.
And just to remind those watching today, you can call Dr. Patolia and Dr. Steckel's office and request an appointment, and we'll give you that number at the end of this Facebook post. It'll be 314-977-6190. And it looks like we've got a couple more questions coming in, which is great. Hillary says, I have such severe allergies and asthma and very thick mucus that closed off my breathing and put me in cardiac arrest. I was in the ICU for 8 days. I'm a SLU care patient. Would I be a good patient for this?
It's hard to, without actually seeing and talking to the patient, it's hard to say absolutely yes or no, but there's one thing that gives me great pause. Generally speaking, we're looking for patients whose asthma has not led to a life-threatening event such as cardiac arrest, need for prolonged intubation, et cetera. Those patients were not studied. And we do know that when you're undergoing this procedure, there is a tendency during and after the procedure for a few days to have an increased risk of having an asthma exacerbation, and certainly we wouldn't want that to occur in someone that's had such a profound exacerbation that she actually had cardiac arrest.
Hosea says, how long does this procedure take?
Well, each session takes around 30 minutes to an hour. It's usually done under moderate sedation or general anesthesia. We prefer general anesthesia so that patient is comfortable and we can do procedure as long as it takes. And it has to go through 3 different sessions. So 30 minutes to 1 hour times 3 is the total duration of the procedure.
Another question, does this procedure help with exercise-induced asthma?
Exercise-induced asthma, if the patient just has exercise-induced asthma, I suspect there's many other treatments that would be tried initially, okay? Now, if they have exercise as one of their triggers, but all in all, because of the other preponderance of disease and possibly other triggers, that the patient does have severe persistent asthma, then they may be candidates. But I would say it's unlikely that someone with just exercise-induced asthma would be a typical candidate for this procedure.
This is all we are going based on the studies. The studies were done on a specific population. So that's where the best evidence is. So that's where can it be done outside based on individual patient can be considered, but it has to be extensively discussed with the patient to make sure they understand you are not a person who was included in the study, so we won't be able to tell you 100% this is the benefit you will get.
Okay. And George says, what level of anesthetics are used in this procedure? You mentioned that there were 3 procedures. How long is each procedure? Are the procedures outpatient?
The procedures are outpatient. Generally speaking, we'll use general anesthesia, so the patient is actually completely sedated, and they're on a machine that will actually breathe for them during the procedure. You can also do the procedure under moderate sedation, the sort of sedation you would get to undergo let's say a colonoscopy or something like that. Again, as Dr. Patolia had mentioned, the procedures will last anywhere from 30 minutes to about an hour. And you'll undergo 3 separate procedures, and each procedure is separated by about 3 weeks in time.
Okay. Dr. Patolia, can you tell us about some of the risks, if there are any, associated with bronchial thermoplasty?
The most common risk which was seen in study was, as I mentioned, was the exacerbation of asthma immediately post-operative or during the period. The risk is, by studies, 8 out of 100, 8% versus in the study, the control group also had 2% risk of exacerbation. So 8% versus 2% control. That's why we choose the right patient at the right time, and we give steroid. But despite that, there may be a short duration of hospitalization required if the exacerbation is severe enough that we don't think it's safe for me to send you to the home. So maybe 1 or 2 days of the hospitalization. That's the main the complication of the procedure.
Okay. Can you tell us, Dr. Steckel, is bronchial thermoplasty different from any of the other asthma treatments, and if so, how?
It's very different. It's the only treatment that's not based on a drug. It's the only treatment that one can undergo once, or these series of bronchoscopies, undergo that, and then have a durable response without the patient really doing anything, other than continuing whatever their asthma medications that they're on. But as opposed to all the other treatments, they're always based on a drug, usually inhaled medications, sometimes injectable medications, sometimes oral medications. And they have to continue on these. And I know I've had patients ask all the time, well doc, I'm thankful that my asthma's under better control, but how long do I stay on this medication? And a lot of times I have to tell them, a long time, maybe forever. Now, there's always a chance that the patient's asthma over time will change, will improve, and they'll be able to come off medications. But a lot of patients are going to be on those medications for a long period of time. And bronchial thermoplasty is very different in that regard.
And to add on that one, I would add that the treatment for the allergy which we are talking is injectable. It's done at least once or twice a month. And for that, you have to stay in the physician's office for 30 minutes to 2 hours post-injection for monitoring. So we are talking about 2 visits in a month for almost 3-4 hours. That is almost 2 days gone out of a month for rest of your life. If it is allergy-related asthma, you are just trying to control the end product of the allergy, not the actual allergy. So you will have to stay on the treatment for almost lifelong, if that is the treatment you choose.
We've got another question from George. Are the procedures painful? And what follow-up does the patient undertake after the procedure? Dr. Steckel?
Well, I would say, George, no, they're not. It's not a painful procedure. Again, we're doing these preferably under general anesthesia, so you really shouldn't feel a whole lot of you shouldn't feel anything during the procedure. Now, afterwards, you're going to be tired, maybe forgetful briefly because of the anesthetic. Your throat may be a little sore, your chest may be a little sore, you may be a little short of breath. You may have a bit of a cough. There's always that chance of exacerbation that Dr. Patolia mentioned after the procedure. But no, during the procedure, the patients are very comfortable and it's not painful. And I'm sorry, Wendy, what was the second portion of the question?
The second part is, what follow-up does the patient undertake after the procedure?
Okay. We want to stick in, stay in close contact with these patients. So we're gonna see them back usually within a few weeks after the procedure. They're gonna have the ability to get a hold of us should their asthma kind of flare up following the procedure. But very close follow-up, certainly.
Okay. And then we've got another question here. Would my insurance pay for this procedure?
So before we go through any procedure, we make sure that the insurance has approved. We have some specialists who can help us to pre-authorize. So most of the time, we are able to get through it as long as you fulfill the criteria and we have demonstrated to the insurance that you have been on the treatment for a long time, other treatment, and you are still in control, and this is we are doing at the add-on therapy. So yes, with the help of the a specialized person, we can always get a pre-authorization most of the time. That doesn't guarantee every time, but most of the time.
Okay. A couple more questions here from Patricia. Does the patient show improved PFTs?
Interesting. Typically, no. Okay. In the studies, what they've found, which I find very interesting, when we look at PFTs of patients that have asthma, and many times they're normal. Okay. But if there is an abnormality, that abnormality is probably going to be a reduction in their ability to exhale. And we measure that using something called an FEV1. And what they've found is in patients that undergo bronchial thermoplasty, their FEV1 remains stable, okay? Which is good and bad. In a sense that we certainly are glad that the FEV1 remains stable and doesn't decline over time. But it's kind of interesting. Most people would think, well, it should improve. It doesn't. It actually does remain stable. But what we're interested in is the symptoms improve. The ER visits improve. The exacerbation rate improves. The need for oral steroids improves. So we're satisfied with that. But no, the PFTs themselves should not change.
Okay. And then a question from Rosemary. Would this help a patient with
sarcoidosis?
Thank you.
Sarcoidosis.
Well, the sarcoidosis, it will not help because the pathophysiology is totally different. What we are treating in asthma is just around the breathing pipe, there are smooth muscles. All of us have it. And with chronic asthma, that smooth muscle increase in the size and get hypertrophied. And they are hyper-responsive, so your breathing pipe is narrowed, and anytime a small trigger can narrow down your breathing pipe. And by applying that radiofrequency ablation, what we are trying to do is decrease the size of the smooth muscle. Sarcoidosis have a total different pathophysiology, so it won't work for that. And on the previous question with Dr. Steckel, in the past, we were worried about the bronchial thermoplasty may actually reduce the lung function because we are applying the electric current that may lead to scar. But over the study, when they did the follow-up of those patients who underwent the study during that trials, they found out that PFT remained stable and there was no effect of scarring. So at least we are happy with the stable PFT with reduced exacerbation in BT patients.
Great. Dr. Steckel, what is the role of prednisone in the treatment of asthma?
Lisa, you're bringing up something that is very can be very frustrating for both the patients and the physicians. Oral steroids, prednisone, are occasionally required in patients that have severe uncontrolled asthma. We like to stay away from them simply because even though they can help the patient breathe better and help them through an exacerbation, they have such profound side effects. They have side effects that involve the eyes. They can cause problems with glaucoma, cataracts. They can have problems with the skin. They can have problems with fluid building up, particularly in the lower extremities. They can have problems that develop with the bones, where the bones become fragile, and other metabolic type problems. And finally, they can cause problems with mood. I mean, some people get real anxious and nervous and can't sleep while they're on steroids. Conversely, there's some people that get actually a little bit of almost a high from steroids, but they're a necessary evil, if you will. At times, we do have to use them in our patients with severe asthma, but we would like to keep the use to a minimum just because of the profound number of side effects.
What are the risks associated with frequent use of the oral steroids? And can you explain both the immediate and long-term effects, Dr. Patolia?
So the immediate effect is patient will start gaining the weight. Their sugar control will go out of control. Blood pressure can go up. Over long term, it can increase the risk of infections. It can lead to osteoporosis with fractures of the bones, lead to cataract and glaucoma. Also, if you are on the prednisone for a long time, that affects one of the gland called adrenal gland, and that becomes atrophied because of the chronic use of steroid. And then you become dependent on the steroid, because once you withdraw the steroid, body has not ability to produce any more steroid by itself, and you go something we call adrenal crisis, where your blood pressure drops, you feel dizzy, and your electrolytes go abnormal. So yes, if after a chronic use, fractures, adrenal insufficiency, glaucoma, uncontrolled blood pressure, uncontrolled sugar, wound infections, obesity, weight gain, edemas are the side effects most commonly seen.
Dr. Steckel, has bronchial thermoplasty reduced the oral steroid use in your asthma patients?
You know, for myself, it's hard to, I can't speak to that, but the overall, in studies, there has been a reduction in oral steroid use, yes. And you know, that's a huge benefit to this sort of treatment, you know, to get patients off these medications with such profound side effects.
Great. Dr. Patolia, is there an urgent need for better asthma treatments, and do you think that bronchial thermoplasty can help fill that need?
Yes, and the reason why I say yes is, as I mentioned before, the asthma is chronic progressive disease, and you do not want to reach a stage where it becomes irreversible in the PFT. And once you reach that stage of irreversibility, even the bronchial thermoplasty cannot help you. So to prevent patients from going to an irreversible stage, there is a need, and bronchial thermoplasty is one of the treatment we use to help the patient before they reach that stage.
And Barbara, I should point out, there is, you know, 1 in 8 Americans is thought to have asthma, and now that equates to about 25 million people in the United States that have asthma, and about 10% of those patients actually have the kind of asthma that we're involved with treating the patients with severe asthma. So it's a huge number of patients that have this disease.
Great. And then patients frequently talk about the dramatic difference in their lives before and after bronchial thermoplasty. Can you share some of those anecdotes with us?
Well, I had a patient in my previous hospital where I used to work before I joined SLU, where I treated the patient with the bronchial thermoplasty, and that was right patient at the right time, and that led to a total different in quality of their life. He was able to enjoy his life without being afraid of exacerbation. His number of exacerbation went down. So yes, that did help him a lot.
Yeah, I think that the patients, once you get their asthma under control, sometimes they don't, you know, they certainly don't realize the impact asthma has on their lives. But I'm thinking of one patient where this person was driving into our emergency room here in St. Louis, and they were driving in 2.5 hours, probably once or twice a week. I mean, that's a huge burden, not only on the patient, but on the patient's family. And when you finally get the patient's, when we finally got this patient's asthma under control, now we didn't use bronchial thermoplasty, but when we finally were able to control the patient's asthma, he now does not need to come into the emergency room, doesn't have to drive 2.5 hours to get here to St. Louis University. He sees me about once every 4 months or so.
That's great. So thank you today, Dr. Steckel and Dr. Patolia, for joining us today. That's going to wrap up our time today. And to make an appointment with one of these fantastic slew care pulmonology specialists, you can contact them at 314-977-6190. Thanks for joining.
Thank you.